Thank you. Well, first I have to thank the IGC, this time not for funding anything, but for inviting me. It's always a pleasure. What? Oh, yeah. But the research was funded by in a different channel. This is part of a large multidisciplinary study, including political scientists, anthropologists, and economists. Some of what I'm going to present, I'm going to blame on the fact that this is a study by committee. The main purpose of this study really was to figure out how do people in unrecognized slums in Delhi get public services when they're not really entitled to. But that was really the problem of the anthropologists and the political scientists. My concern was very much narrower than that, which was how do bad sanitary and hygienic conditions affect people's health. Good. So I thought I'd start from the end. As is my wont, it's very possible that I'll wander off into irrelevant tangents, and at least you will know what I intended to say in the first place. Also, in case I wander off, the chair can cut me off at any time, and I'll just stop in mid-sentence. So the conclusions of the study are that if water enters your home from the street during the year, people in your house, especially infants, will get sick a lot. The second one is if your neighbors defecate in the open, you and your children will get sick a lot. And what I mean by water entering, water entering your home is these are slum areas, and the streets are in fact just muddy areas, sometimes with paths, sometimes with not. In front of your house is almost always a shallow gutter. So if water comes into your house from the street, it's not a pleasant sight. I had originally done the preliminary work in January and didn't realize exactly how bad things could be. In this past July, after the rain started, I went back to a couple of these neighborhoods and they were noticeably more fragrant. Given these conclusions, if causal, there are certainly obvious policy implications. If water like that comes into your house where there are no or badly maintained sewers, obviously well-maintained sewers in the cities are public goods, or as close to a public good that we ever get in economics. And on the issue of causality, whenever I talk to any audience except economists, everybody looks and says, if water comes in, you're going to get sick, and there's a question that there's causality involved. But I know I have to be more careful around here. As is frequently the case, this is the first time I might have a self-contradictory slide, two contradictions on the same slide. I'm actually not even that concerned anymore about causality in this case. It's who really wants street water coming into their house anyway, whether it actually makes you sick or not. It's something that you can't protect yourself from. It's something you need collective action, a public good, to help solve. And maybe we don't even have to worry about whether there's a causal relationship with health. The second one is people defecating in the open is an externality, particularly if it's somewhere near you. Here, causality might be harder to prove, but in cities at least, the relevant policy is pretty much the same. In rural areas, being able to make areas defecation free might be considerably harder, entails considerably more difficult aspects of behavior change. In urban areas, a good sewer system goes a long way. I was going to use this slide as a throwaway slide, just to make snide comments, but I only ever have two things to say in my entire professional career, and this refers to pretty much any policy and pretty much any time. Of course, the details differ all the each time. And I was just going to skip over this very quickly, except 2 evenings ago, the chief minister asked a very serious question, and I'm not sure we're getting too much closer to giving him an answer. What he asked was, so really, should I be doing transport? Should I be doing infrastructure? Should I be worrying about law and order? Should I be worrying about some of the social services? And these are first-order big problems that the government has to deal with, issues of first-order importance. This involves intersectoral as well as some intrasectoral allocations that I'd like to get to in a second. And I think that we as economists have quite a bit to say on this, with data and without, preferably with. I'd like to be able to inject into the conversation more dimensions that can help him with this decision. Related to this is he recognized that there is a budget constraint. So just because we say something works, or this other thing works, or this thing works, is not sufficient for us. Lots of things are good. The whole point of economics is to try to make decisions between competing good things, and that we might be able to help him out with that. Our theoretical, our traditional answer to this is, why don't we try, if we have a very constrained budget constraint, to provide public goods before we start providing private goods? Or, in a more general context, why don't we fix the really bad market failures first? That's one. That's traditional. That comes from simple public finance, introductory economics sometimes. A little bit more serious is, why don't we try to do things that you can do before you try to do those things that you can't do? Or in this case, take constraints on government's abilities, and both political in some sense, but I really had in this sense some more narrow administrative capacity to actually get things done. So some things are relatively easy to do, some things are relatively hard. We should take a cold look at what exactly it is we can promise our citizens, and this should, in fact, help us have the courage to not do a few things that we think are valuable, just because they're much harder to do. Now, we can try to fix the government policies, if that's possible, and there's been a lot of discussion here about can we improve with social audits. If those end up working, that's great, and if we can get government policies to work better, then the situation changes and our balance between what we do and what we don't do can change. But if we can't change the ability to deliver services, this should be taken seriously when we start listing the priorities for what the chief minister might actually like to do. I think these two things are utterly and totally innocuous statements, but you would be amazed at how bizarre this sometimes sounds in health policy discussions. So in health, this actually helps us a little bit with an intra-sectoral allocations between publicly provided medical care, which is excludable in rival, I might remind you, versus publicly provided public goods. In the rich countries, public goods, that's water, sanitation, pest control, drainage of swamps, traditional public health, traditional in the Western sense public health, were all done in the late 19th or early 20th century. That was before medicine actually had anything to contribute at all except surgery. In the 20th century, currently poor countries have a few extra things that medical sciences has thrown up for us that could be of extreme use. Vaccines are difficult to argue with, but some of the things that have been pushing out the pure public goods in a lot of our countries, India for sure, could have been prematurely, that is, medical care might have prematurely displaced in priority of public expenditure, things that should have been done many years ago. So actually asking these two simple questions, where's the publicness, what are things to do, what's easy and what's hard to do, I'll come back to why it's hard to provide medical services sometimes, can take you a long way in answering some of these questions. Not because we don't like medical care, it's just that it's a little bit harder to do than something with a major market failure associated with it. That was my first concern, which I thought was just going to be minor, but because of the Chief Minister's comments, I thought I'd make a little bit bigger deal of it. For my case, on this, there's emerging evidence on the salience of sanitation, particularly in densely populated areas. This is some work, mostly of former students of mine, on open defecation as height. I think it was mentioned yesterday that South Asian children are much shorter than African children, and one of the concerns that I think might have been overlooked is height, which is a very good measure of the nutritional status of children, is made up of two things. One is how much food comes in your mouth and how much is retained by the body, and that the sanitation conditions that the children are in may have a great deal to do with their ultimate nutritional status. And this is these are the states of India, some of which are labeled sometimes, some of them not, where just a bivariate correlation between the fraction of households practicing open defecation and the average height for age of children. One thing I'd like to notice on this is that Delhi, a rich place, over here on the left-hand side, considerably below the regression line for open defecation versus height. And one of the reasons for that is that if we convert the x-axis from just open defecation, fraction of people, to open defecation per square kilometer, most states don't move, they wiggle around a little bit, no big deal, but Delhi moves from way over on the left to, and outside of the statistically significant band, to way over on the right with one of the highest densities of open defecation anywhere, and much closer to the standard relationship. So whereas you would expect Delhi to be a little bit higher than the rest because it's richer, that was not the case unless you converted this into the density of open defecation per square kilometer. So going back to the 19th century, I can just see that in all of South Asian cities, Lahore probably is a good example, though we'd like to study this a little bit more. The complaints that were made of London in the mid-19th century, Dickens' London, which was miserable and awful, I think is going to start looking pristine pure relative to the South Asian countries, which are many times larger and not yet as well equipped as London in 1854. One of the themes of the conference was supposed to be urbanization. If we do not handle some of these basic infrastructure issues in South Asian cities, there will in fact be, whether or not it actually shows up in lower per capita income, I don't care. There will be a big cost to pay in terms of human well-being if this is not handled. An important emphasis on cities. If you don't really like the wide scatter and the other one, this is the Indian states in international comparison, where I think the relationship shows up a little bit stronger. Way off on the upper left are all the African countries, which was the mystery of why are African countries poorer but taller than South Asian countries. And Pakistan actually has always been considerably better than India. and has been improving and moving straight up this, this curve. This is the Demographic and Health Survey, 1991 and 2006, in comparison to the red circles, which are Indian states. And the 2012 one, which I didn't have time to add, is on a year-by-year basis, even moving up, moving northwest at an even faster pace. So we are on track to improve, but as you see, way over on the side of having much defecation to clean up. This is not our study. This is just some background information. How much time do I got, in case I wasted everything? Okay. So, our study, since it looks like this is a particularly bad problem in urban areas, this should imply a closer look in Delhi. And our study was 4 neighborhoods in unrecognized slums, and we had to do a simple, my colleagues were interested in network effects about who talks to whom to get a water pipe or this, and so forth, and so the sampling was a compromise between a variety of things. We don't have to go into this in detail, but I can show you what the sample looks like. This is one of our neighborhoods. The pink dots are the households. The latitude and longitude is blocked out for anonymity's sake. And we were sort of tracking where are there open defecation areas. This is my part. Open sewers, garbage dumps, sewage outflow, and also, oops. Yeah, okay, I'll do this. And also, in some of the neighborhoods, where did people openly defecate? Where were the hot spots, in a sense, of where lots of people congregated that happened to have open defecation as their main source of taking care of their business? And these are the 2 different kinds of things that we wanted to look at. It was the location of public services, sewers, and also the proximity to neighbors with bad habits. I'm not going to go into this. There's a couple of descriptive statistics. In fact, in a lot of ways, the descriptive statistics here tell a lot of the story. What I really want to show, is there a, no. So, as I said, a really big problem is water comes into your house from the street. Well, how often does that happen? Well, our neighborhoods are quite different. The one I just showed you was actually our richest neighborhood, and it was really only occasionally that water would come into the street, only 7% of the households. However, when we look at some of the other neighborhoods, okay. Oh, good. If you look at some of the other neighborhoods, actually this is, not only was it a richer neighborhood, it happened to be on a hill, so water could flow away. In these 3 neighborhoods, they're quite a bit flatter. There's a lot of stagnant water, and water comes into the house. And in 47% of the households in 2 of the neighborhoods, and in 55% of the households in another. Whether it causes illness or not, this is a miserable way to live, and something that I think should be worried about. Similarly, our richer neighborhood has someone in the household defecates openly only 6% of the time, as opposed to 85%, and quite a range in some of the neighboring areas. And as far as the externality is concerned, do your neighbors defecate in the open? We have, this is not percentage, this is the number of neighbors whose front door is within 2.5 meters of yours. These are densely populated areas. And in 2 of our neighborhoods, at least, we have just about 1 other person lives within 2.5 meters of you, who also happens to defecate in the open, and half in the other neighborhood. So we're talking about a significant possibility of major externalities and solutions being public goods in these neighborhoods. What does this do to health? Well, these are the results in pictures. This is the diarrhea that we found in a 2-week period. It's easiest to explain if we just say, let's take a look at those homes that are clean in every way, that they don't have water coming into their house, and they do not have neighbors or their own open defecation to worry about. And we see that among infants, we have about a 13% chance of having diarrhea in a 2-week period. So this is actually quite a lot of illness. And if you start adding on the other things that could go wrong, having neighbors that defecate in the open, and also having water come into your house, we have that number climbing from 13% to almost 30% in a 2-week period, which means that there's about if we can do this, about 7.8 episodes of diarrhea per year. This will be enough to kill a child. So we have potentially very strong effects in the urban areas that could be fixed if there were more public infrastructure. Just to show that this may not be entirely spurious, there's always a chance that it is spurious, we did do a falsification test, which is these results do not hold for any other health condition. So we're not just sort of saying we are able to identify sick people by the fact that sick people happen to be poor and they have water coming in their home. It has nothing to do with it. This kind of relationship does not hold for fever or coughs or accidents, and childbirth, of course, a terrible illness. The sanitation variables only affect waterborne diseases, and you'd have to have a fairly convoluted argument to say that that for some reason water coming into your house affects waterborne diseases, but not any other diseases for some spurious reason. I'm going to skip, since I have no time. I don't really have policy impact, except maybe a sewer in a major city of 8 million people or 15 million people in the case of Delhi might not be a bad idea. One of my colleagues, Veena Das, the anthropologist, she went and she spoke to some of the neighbors, some of the neighborhood associations when some of the preliminary results, which were not quite right, but they came out to be roughly the same, and shared this information with the neighborhood associations. They knew that water came into their houses. That's something that they can see as well as we can, and in fact, we had to ask them in order to get the response from the survey, but they did not really know that it could have had anything to do with illness. So this actually impressed some of the neighborhood associations, and they went to talk to their member of the Legislative Assembly about being able to clear out the existing drains and extending the system to other parts of the neighborhood that didn't happen. I can't tell you whether anything came of this. All I can say that it could have been a source of a groundswell of political support for having these services. Discussing neighbors' habits was a little bit more sensitive, and in fact indicates that it might be a little bit harder to change behavior than to build infrastructure. I think it's only responsible for economists to deal with. There is a budget constraint. I said that we should be doing this, so maybe we should worry about what should we not be doing. A lot of times people just say, here's proof that my thing is really good, so we should spend money on that without thinking where the money might come from. I have a suggestion for where the money of this might be reallocated. This is work that I did with Jishnu Das some time ago. It's not contemporaneous. Just to tell you that the ability for the government to run primary health care centers in India is very, very tightly constrained. It's very difficult. It's, telling doctors what to do, especially bureaucrats telling doctors what to do, is sort of like herding cats. They're of much higher social status. They just don't listen to administrators. In fact, in Delhi per se, we have incredibly low quality care being provided in the public sector. There's a famous Indian Nobel Prize winning economist who will go nameless, who described the private sector in health in India as a den of quackery and crookery. That's the private sector. What this diagram shows is, we can't go into great detail, two measures of the quality of medical care. One is, what do doctors know? Those are the blue dots. And one is, what do they do? which is how much time do they spend with patients. That's effort in practice. What they know is blue, and what they do is red diamonds. And I think a reasonable way of quackery, of defining quackery, is not knowing very much about medical care. Well, in this particular way, the way we measured it, this was normalized so that the mean is 0, and the indications are standard deviations. And the lowest quality competence of any doctor in Delhi was primary healthcare doctors with MBBS degrees in poor neighborhoods in Delhi. This is in comparison to private doctors, and I use the word loosely because private practitioners in Delhi included people that we would all agree are quacks, that is, people with no education whatsoever, yet they seem to have better qualifications than our MBBS doctors in Delhi who got their MBBS degrees free from the government, of course. And then, that's not nearly as dramatic as the other result, which is effort in practice, which was a measure of how much time do you spend, how many questions do you ask, and how many procedures do you, test procedures, which includes if someone came in saying, I have a fever, does the doctor touch your forehead? That would have counted as a procedure. There, the only people who are just way off the charts are primary healthcare doctors in public facilities in Delhi, where there was an average of 2 minutes apiece, one question, and the question was, "Kya hai?" So not even a particularly nicely phrased question, and no examinations whatsoever. So if I were to say, do you need, so when I conclude that sanitation could be a really important thing, sewers are public goods, and if water enters your home from the street during the year, people in your house will get sick. You've seen this before. And that sewers will also take care of your neighbors defecating in the open, which will also get your children sick. And I advocate for saying we should do a lot more than this. If you want to ask me where's the money going to come from, I would say it would be from other things that we do in fact waste money on. Thank you.